For more than 100 years, appendicitis meant one thing: surgery. But what if it didn't have to? Today, we're going to break down the CODA trial, a huge study that really shook up that old school thinking. And trust me, what they found could totally change how you approach one of the most common surgical problems out there. And this is the question that started it all. It didn't come from a researcher. It came from a patient. And it's so simple, right? But to answer it, well, that took a massive, practice-changing clinical trial. All right, let's set the scene. Imagine you're in the ER. A 25-year-old comes in. Classic story, CT confirms appendicitis. Your brain automatically goes to, okay, call surgery. It's muscle memory. But then your patient looks at you and asks that question. Suddenly, 100 years of standard practice is being challenged right there in your exam room. And this isn't just some textbook case. It's the exact real-world situation the CODA trial was designed to tackle. So here's how we're going to break this down. First, we'll look at why we even needed to ask this question. Then we'll dive into how they designed the study. After that, we'll hit the big results, both the headline and the really important details hiding underneath. We'll also talk about reading the fine print, the study's limitations. And finally, we'll wrap up with the new bottom line for you in the clinic. All right, let's jump into part one, a patient's question. You might be wondering, why on earth did we need a huge, expensive trial for something as bread and butter as appendicitis? Well, for ages, appendectomy was just what you did. It was the gold standard, no questions asked. But, the idea of just using antibiotics wasn't brand new. It's actually been floating around for more than 60 years. The big problem was that the evidence just wasn't very good. The studies were small, and this is key, they tended to cherry-pick the easy cases. They would exclude the really high-risk patients, like someone with an appendiculith, that little stone in the appendix that spells trouble. So that left this massive question mark. Could antibiotics actually be a safe bet for the everyday diverse patients we see walking into the ER? So when you have a question that big, you need a seriously robust experiment to answer it. That brings us to section 2. Let's look at how they actually designed the CODA trial. Let's do a quick PICO breakdown. The population? Over 1,500 adults with confirmed appendicitis. And really importantly, they made sure to include those higher-risk patients with appendical lifts. The intervention was a 10-day course of antibiotics. The comparison? The usual suspect, appendectomy. Now, the outcome is where it gets really interesting. The primary outcome wasn't just, was the infection cured? Nope. It was the patient's health status at 30 days using a quality of life score. That tells you right away that they were focused on what really matters to the patient. And that brings us to a really key concept you have to understand here. This was a non-inferiority trial. What does that mean? Well, the goal wasn't to prove that antibiotics are better than surgery. It was just to show that they're not unacceptably worse. Basically, are antibiotics a good enough alternative to even be considered a viable choice? That was the bar they were trying to clear. Okay, on to section 3, the results. Now, the main finding is what you probably saw in the headlines. But the real story, the part that you really need to know for your clinical practice, is buried in the nuances. So here's that big headline result. Based on how patients felt at 30 days, antibiotics were officially non-inferior to surgery. The trial hit its primary endpoint. So, great, antibiotics work. End of story, right? Well, not so fast. Because this number right here, this is the plot twist. Almost 30%, nearly 1 in 3 of the people who got antibiotics ended up needing surgery anyway, and that's just within the first 90 days. This is where that simple antibiotics are just as good story starts to get a lot more complicated. And if you dig just a little deeper, the story completely splits in two. For patients who had an appendiculith, the chance of failing antibiotics and needing surgery shot up to 41%. But for those without an appendiculith, it was much lower, down at 25%. So this one little thing you can see on a CT scan turns out to be a massive predictor of whether antibiotics are going to work or not. This curve from the actual study shows it perfectly. See how the two lines split apart? The top line represents the patients with an appendiculith. You can see it just takes off, separating right away. It shows a much higher and faster rate of needing surgery over those 90 days. We're not talking about a small difference here. This is a huge, clinically meaningful divide. And the plot thickens when you look at complications. At first glance, it looks bad for antibiotics. more than double the complication rate compared to surgery. But that number is super misleading. Why? Because pretty much that entire increased risk was concentrated in one specific group. You guessed it, the patients with an appendiculith. If you take them out of the equation, the complication rates were basically the same for both groups. So you can see it's all about trade-offs. On the plus side for antibiotics, patients missed way fewer days of work. And get this, almost half of them were treated completely as outpatients, never even getting admitted. That's huge. But there's a downside. They were also more likely to bounce back to the ER or need to be hospitalized later on. So it's less of an ordeal up front, but it comes with a bigger risk of needing more care down the road. All right, let's move on to Section 4. This is where we need to be really sharp. No study is perfect, and honestly, understanding a trial's limitations is just as important as memorizing the results. This is crucial stuff, not just for your exams, but for real life. Yeah, this quote says it all. The CODA trial is a total game changer, no doubt about it. But we have to be smart about how we use these results, keeping its limitations and potential biases front and center. So what's the fine print we need to worry about? First off, the follow-up was only 90 days. That's pretty short, so we don't really know what the long-term recurrence rate looks like. Second, it was non-blinded, meaning patients and doctors knew who got what treatment. That could totally bias how patients reported feeling. Third, there's a big potential for selection bias. Think about it. Only about a third of the eligible patients actually enrolled. Are those people different from the ones who said no? Probably. And lastly, it was a pragmatic trial, meaning things weren't super standardized across all the different hospitals. All of this is really important context to remember. Okay, let's pull all of this together in our last section here, the new bottom line. How do we take everything we've talked about, the big result, all the tricky details, the limitations, and actually use it when we have a patient sitting in front of us? It really boils down to this kind of thinking. An antibiotics-first strategy is a totally reasonable choice for the right patient. We're talking about someone who's stable, has no appendiculith on their scan, and gets that there's a chance they might end up needing surgery down the line anyway. But on the other hand, you should really be pushing for surgery if you see that appendiculith, if there are any signs of a serious infection like sepsis, or honestly, if the patient just says, look, I want this taken care of once and for all. So if you remember nothing else, remember these 5 points. 1. Based on how patients feel at 30 days, antibiotics are a viable option. 2. But almost a third of them will need surgery within 3 months. 3. That appendiculith is the biggest red flag for treatment failure and complications. 4. It's a trade-off. Antibiotics mean less time off work, but more trips back to the doctor. And number 5, the most important one, this isn't about a new rule book. It's about empowering a shared, patient-centered decision. So in the end, the CODA trial didn't give us a simple winner. There's no easy, one-size-fits-all answer here. Instead, it gave us something way better. It gave us an evidence-based choice. It gave us the data we need to sit down with our patients and have a real conversation, turning a century-old rule into a modern shared decision. The only question left is, how are you going to use it?